All right, let's dive into neurofibromatosis. Today we're focusing on what matters to you as a neuro-ophthalmologist. The stuff that'll really make a difference in your practice.
Yeah, it's a fascinating area, especially with all the ways these conditions can affect vision.
Exactly. So first things first, just to be sure we're all on the same page, we're talking neurofibromatosis, or NF, right? A genetic disorder, primarily affecting cell growth in neural tissues. And, well, obviously that has huge implications for the eyes.
For sure, absolutely. And it's important to remember there are two main types, NF1 and NF2. And get this, both can present in segmental patterns, meaning symptoms might only be in certain areas of the body.
So not always a full body presentation.
Yeah.
I imagine that makes diagnosis tricky sometimes.
Yeah, you got it. Like trying to solve a puzzle, but with, like only half the pieces.
Well, hopefully this deep dive will give our listener all the pieces they need. We'll be covering everything from Licht nodules on the iris to the complexities of optic nerve gliomas. Oh, and even some unexpected stuff like eyelid deformities and retinal abnormalities.
A real mix of clinical presentations, each with its own unique challenges for diagnosis and management.
Okay, let's start with neurofibromatosis type 1, NF1. The more common type, it affects about 1 in 4,000 people. So chances are you've seen patients with this in your practice already.
Probably, yeah. And you'll probably see even more. See, NF1 is inherited in an autosomal dominant pattern, so one copy of the mutated gene is enough to cause it. But there's this thing called irregular penetrance and variable expressivity.
Hold on, big words. Can you break that down for our listener? What does that mean for someone with the NF1 gene?
Okay, so imagine a raffle ticket. Just because you have a ticket doesn't guarantee you win, right? That's kind of like irregular penetrance. Not everyone with the NF1 gene will actually get the disorder. But even if they do win and develop NF1, the prize can be different for everyone. Some get small prize, others the jackpot. That's variable expressivity. Symptoms and how bad they are can be totally different, even in the same family with the same gene.
Like a genetic lottery, huh?
And to add to the complexity, about half of NF1 cases aren't even inherited, right? They're from new mutations.
Yeah, like the genes just decided to mix things up. All this comes down to the NF1 gene itself, which sits on chromosome 17. This gene makes a protein called neurofibromin.
And what does neurofibromin do?
Think of it like the brake pedal for cell growth. When the NF1 gene is messed up, neurofibromin is either missing or doesn't work right. So the brakes are off and cells just grow out of control.
And that's what leads to the tumors we see in NF1, like those optic nerve gliomas and Licht nodules, which are often like the first signs we see as neuro-ophthalmologists.
Now, genetic testing can be super helpful. It's about 95% accurate in diagnosing NF1, but there are rare cases where someone tests positive but never actually develops it. Goes back to that whole penetrance and expressivity thing.
Okay, genetics down. Let's zoom out a bit. What systemic features of NF1 should our neuro-ophthalmologist be aware of? I know we're focusing on the eyes, but it's helpful to understand the whole patient, right? You're totally right. That broader view is super valuable. Systemic features, basically. That's how NF1 shows up, beyond just the eyes. And a key thing here is the development of neurofibromas.
And these neurofibromas can basically show up anywhere along the nerves, right?
Pretty much, especially peripheral and autonomic nerves, even internal organs. But, crucial detail for you, they don't grow on purely motor nerves, so that's one less thing to worry about.
Good to know. So what are we looking for specifically? How do these neurofibromas actually present?
Well, different ways, actually. Some are solitary nodules, like little bumps under the skin. Others are more diffuse, forming plexiform lesions, and those can cause, a lot of overgrowth in the surrounding tissue, which can be pretty alarming for patients. Sometimes it's even called elephantiasis nervosa.
Whoa, that sounds intense.
Definitely paints a picture. And then there are the café lait maculas, those light brown spots. They look like coffee stains, often appear in the first year of life, and they tend to grow and multiply as the child does.
And those are pretty characteristic of NF1, right?
Oh, yeah, definitely. And then around age 10, you start to see axillary or inguinal freckles, which are a dead giveaway for NF1, what we call pathognomonic, meaning they're basically specific to this condition.
So neurofibromas, skin spots, what else are we looking for in our NF1 patients?
Well, NF1 can also affect the skeleton. Think
Correct.
short stature or even facial hemiatrophy, where one side of the face is underdeveloped.
And that's the neuro-ophthalmology connection, right?
Yeah.
Because those skeletal issues can impact facial features and cranial nerve function, which can really affect the eyes and vision.
Exactly. And let's not forget about intracranial tumors. Meningiomas and gliomas are more common with NF1, and where they are and how they grow can be a big deal from a neuro-ophthalmological perspective. So, something to always keep in mind.
I know this is a tough topic, but we should also mention the potential for complications with NF1.
Right. Unfortunately, there's an increased risk of malignancy, especially a type of cancer called malignant peripheral nerve sheath tumors, higher chance of gastrointestinal stromal tumors too, hypertension, learning difficulties, and even autism spectrum disorder, which some studies suggest affects almost half of all NF1 patients.
Wow, that's a lot to consider. Really shows how important it is to look beyond just the eyes when dealing with NF1.
I agree. It's about seeing the whole forest, not just the trees, you know.
Okay, so we've covered the systemic stuff. Now let's get to the heart of it, the ophthalmic features of NF1. This is where it gets really interesting for you as a neuro-ophthalmologist.
For sure, for sure. And I can't stress enough how important regular eye exams are for these patients, like right from diagnosis. Early detection of stuff like optic nerve gliomas is crucial.
Okay, so let's go through some of the specific eye problems. What should our listener be looking for?
One of the most noticeable things is eyelid plexiform neurofibroma. Creates this like S-shaped deformity of the upper eyelid.
I've heard it described as having a bag of worms texture. Not exactly a nice image, but you definitely remember it.
Memorable for sure. Now, moving on to the orbital features, the big one is often optic nerve glioma. Shows up in about 15 to 40% of NF1 patients.
These are typically pilocytic astrocytomas, right? Usually in younger kids.
You got it. They cause this fusiform enlargement of the optic nerve, which can lead to like a slow, painless proptosis, the bulging of the eye, and often you'll see significant visual impairment, optic atrophy, and strabismus too.
And here's where it gets tricky, right? These optic nerve gliomas in NF1 can actually affect both eyes.
Yeah, they can be bilateral. And they don't always stay in the optic nerve either. They can spread back, involve the chiasm, the optic tract, even the hypothalamus. Sometimes this can even cause obstructive hydrocephalus, a fluid buildup in the brain.
Sounds pretty serious.
It can be, but the good news is that these tumors tend to grow slowly. One more thing to keep in mind. Optic nerve gliomas aren't the only orbital tumors you might find in NF1 patients.
Right, there are others.
Exactly. You might see neurolimomas, also known as schwannomas, or plexiform neurofibromas in the orbit itself, even meningiomas. So it's really important to, think about all the possibilities when you're evaluating an NF1 patient with orbital signs.
So many things to consider.
There are. And then there's this interesting thing called sphenoorbital encephalocele. Have you heard of this one?
I have, but I'm sure our listener would love to hear about it.
Well, it's caused by a missing part of the skull, specifically the greater wing of the sphenoid bone. This creates a gap, and, well, you can imagine part of the brain starts pushing through that gap into the orbit.
Wow. So you end up with pulsating proptosis.
Exactly. Pretty dramatic presentation, and a good reminder of why a thorough clinical exam is so important.
Okay, moving on from the orbit, let's talk about the iris. This is where those classic Lisch nodules are, right? Tell us more about them.
Ah, the Lisch nodules. Found in almost all NF1 patients, like at least 95%. They're hamartomas, basically benign growths appearing usually in the 20s or 30s. They look like tiny pigmented nodules, kind of poking out from the surface of the iris.
Like little bumps on the colored part of the eye?
That's it. Really helpful clue when diagnosing NF1. Now, while we're talking iris lesions, we should also mention congenital ectropion uvea, which is when the pigmented layer of the iris folds outward. Not super common, but it can be linked to glaucoma.
Interesting. Any other iris things we should know?
Well, there's also iris mammillations, little nipple-like projections on the iris. Pretty rare, but worth knowing about.
Okay, good to know. So beyond the iris, anything else to pay attention to?
Well, here's a tip. You might notice something interesting about the corneal nerves in NF1 patients.
Really? What's that?
They can be pretty prominent. Subtle sign, but something to keep in mind.
Now, what about glaucoma? It's not as common in NF1 as some other things we've discussed, but it can happen.
Right. And when it does, it's usually only in one eye and often present at birth, what we call congenital glaucoma. Interesting thing is, about half of these cases have an ipsilateral neurofibroma of the upper eyelid and facial hemiatrophy.
So again, those systemic features impacting the eyes. It's all connected.
Exactly. Shows the importance of that whole patient perspective.
Okay, so now let's focus on the fundus. What might we find there in our NF1 patients?
Well, if a patient has choroidal naivety, those are benign pigmented lesions on the choroid, they have a higher risk of developing choroidal melanoma. So, important to monitor those closely.
Makes sense. What else are we looking for in the fundus?
There are these cool things called retinal corkscrew vessels. You'll find them in about a third of patients. Literally look like tiny corkscrews. And importantly, they don't leak.
Good to know. Anything else?
Oh, yeah. These interesting choroidal hyperreflective nodules, often seen on OCT analysis,
What are those? I don't think I've heard of them.
they're found in over 80% of NF1 patients, making them a really strong indicator of the condition. They're like little beacons saying, hey, this person probably has NF1.
So see those nodules on an OCT? Good bet it's NF1.
Exactly.
Okay, to wrap up our NF1 fundus findings, any other lesions we should be aware of?
A few other things might be more common in NF1 patients compared to the general population. Things like congenital hypertrophy, the retinal pigment epithelium, myelinated nerve fibers, combined hamartoma of the retina and RPE, and retinal astrocytic hamartoma.
So many possibilities.
I know, right? A lot to keep track of, but you're doing great. And just a quick note, those retinal astrocytic hamartomas are identical to the ones seen in tuberous sclerosis, another genetic disorder that can affect the eyes.
So there you have it, a whirlwind tour of the fascinating and, well, sometimes challenging world of NF1. It's amazing how many ways NF1 can show up, especially in the eyes.
It really is. It shows just how connected our genes, nervous system, and vision are.
Absolutely. Before we move on, though, I just want to make sure our listener feels good about tackling NF1 in their practice.
Yeah.
Any key takeaways you want to highlight?
Definitely. When you see an NF1 patient, always think about the possibility of both sides being involved, especially with things like optic nerve gliomas. And don't forget those other orbital tumors that can look like gliomas, the neurilomomas, plexiform neurofibromas, and meningiomas.
So always have a broad differential, right?
Exactly. And when it comes to those Lish nodules, they're super helpful for diagnosis. See those? It's a strong sign you're dealing with NF1.
Great point. Okay. I think our listeners ready to take on NF1. Now, let's switch gears and talk about neurofibromatosis type 2, NF2. You mentioned it's less common than NF1.
It is, yeah. And while it's got the same name, neurofibromatosis, NF2 is a totally different thing, genetically speaking. It's caused by mutations in the NF2 gene on chromosome 22. This gene is responsible for making a protein called Merlin.
Merlin, like a wizard.
Well, not quite a wizard, but it does some pretty important stuff. Merlin's job is to keep cell growth under control and make sure cells are organized the right way. So when the NF2 gene is messed up, that control is lost and things get out of hand.
And just like NF1, it's inherited in an autosomal dominant pattern.
Mm.
But you said earlier that about half of NF2 cases are actually sporadic, meaning they just happen without a family history. Why is that?
Still a bit of a mystery, honestly, but it probably has to do with new mutations popping up in the egg or sperm cells. So even with no family history, you got to keep NF2 in mind, especially when you see certain characteristic signs.
Like what? What should make us think of NF2?
One of the most common, and often the first sign, is a vestibular schwannoma.
Ah, those benign tumors affecting the nerve for balance and hearing.
That's the one. And you see them in about 90% of NF2 cases. Other things to watch for include a family history of NF2, juvenile cataracts, neurofibromas, meningiomas, gliomas, and schwannomas in other parts of the body.
So kind of the same players as NF1, but the mix and how they show up are different?
Exactly. And here's where you come in with your neuro-ophthalmology expertise. The eyes are often the first place NF2 shows up, so being able to spot those early signs is so important.
Okay, let's dive into those ocular features of NF2. What are we looking for?
One of the most common findings is cataracts. They affect about 2/3 of NF2 patients.
So every time I see cataracts, should I be thinking NF2?
Well, it depends. The cataracts in NF2 aren't like your typical age-related ones. They show up much earlier, often before age 30, and they can look different too. Posterior, subcapsular, capsular, cortical, or even a mix of all of them.
So young patient, cataracts that look a little unusual, NF2 should be on the list.
Absolutely. Now, when we look at the fundus, we often find epiretinal membranes in NF2 patients.
Remind me, what are epiretinal membranes again?
Basically, thin layers of scar tissue that form on the retina surface right over the macula.
Ah, okay. And the macula is that central part of the retina for short vision, right?
You got it. So you can see how these membranes cause problems. Patients might complain of distorted vision, like looking through wrinkled plastic wrap. Sometimes it can even lead to vision loss.
Sounds frustrating.
It can be, for sure. Another common finding in the fundus is combined hamartoma of the retina and retinal pigment epithelium, or RPE.
Okay, break that down for me. Combined hamartoma, what is it?
A hamartoma is like a disorganized growth of tissue, but it's benign. And in this case, it involves both the retina and the RPE, the layer that nourishes the retina.
So it's a tumor, but not cancerous.
Exactly. Usually benign, don't cause any problems. But depending on size and location, they can sometimes interfere with vision, something to keep an eye on.
So he's got cataracts, epiretinal membranes, and combined hamartomas. What other surprises does NF2 have in store for us?
Well, about 10% of NF2 patients have ocular motor defects. Think double vision or trouble moving the eyes smoothly in certain directions.
So these patients might have trouble coordinating their eye movements.
Exactly. And that's usually because of cranial nerve palsies. Those nerves control eye movement, and in NF2, they can be affected by the tumors we've been talking about.
Makes sense. Anything else we should be looking out for?
A few less common things, but still good to know. You might see optic nerve sheath meningiomas.
Meningiomas. Aren't those brain tumors?
They can be, but they can also happen around the optic nerve. These tumors can press on the optic nerves, lead to vision loss.
Something we definitely don't want to miss.
For sure. And here's where things can get a bit tricky. You might also see optic nerve gliomas in NF2, just like in NF1. But the key difference is, with NF1, Lisch nodules are almost always in both eyes. But with NF2, they can be in just one eye.
Okay, important distinction. Lisch nodules. Both eyes in NF1, maybe just one in NF2. Got it? Anything else?
Just one more thing. Some NF2 patients might have abnormal electroretinograms or ERGs.
Oh, right, those tests that measure the electrical activity of the retina.
Right, so if you suspect NF2, an ERG can be a helpful part of your diagnosis.
Okay, so we've covered a lot. NF1, NF2, all their ocular stuff, and even some exciting new treatments coming up. Is there anything else you want to add before we wrap up this deep dive?
You know, I think it's important to remember that beyond all the science and jargon, we're dealing with people facing real challenges.
That's a really good point. It's easy to get caught up in the details and forget the human side of things.
It is. So as neuro-ophthalmologists, it's our job to not only diagnose and treat these conditions, but to support our patients and their families.
It's about more than just the eyes. It's about the whole person.
Exactly. It's about compassion, empathy, and wanting to help people live their best lives despite these challenges.
Well said. That's a great place to end. I think our listener is feeling much more ready to navigate neurofibromatosis and provide excellent care to their patients.
I hope so. It's been great sharing my knowledge and thoughts with you today.
The pleasure was all mine. Wow, I feel like we really covered a lot today. NF1, NF2, all the eye stuff, the potential problems, and even some exciting new treatments on the horizon. A lot to take in, but I hope our listener is feeling, energized and ready to use all this in their practice.
I hope so too. It's always great to share info that can really make a difference in how we care for patients. And I think one key takeaway is that neurofibromatosis, as complex as it is not like an impossible challenge. With the right knowledge, careful observation, and teamwork, we can really have a positive impact on these patients' lives.
For sure. We've got the tools, the technology, and most importantly, the passion to make a difference. But there's always more to learn. So before we wrap up, I want to leave our listener with a little challenge, something to think about as they keep exploring this whole neuro-ophthalmology world.
I like that. A little something to chew on.
Exactly. So here's the question. We talk about how NF1 and NF2 can sometimes have similar features in the eyes, which can make diagnosis tough. What strategies can we use to make our diagnosis more accurate? And how can we use the latest imaging to catch these conditions early?
That's a great question. Really gets at the core of what we do as neuro-ophthalmologists. And I think the answer is multifaceted. We need to keep getting better at recognizing those little signs and symptoms that can point us in the right direction.
So keep sharpening our diagnostic skills.
Exactly. And we got to stay up to date on the latest imaging tech. OCT, MRI, and even newer stuff, they're giving us amazing views of how the eye and brain work.
So embrace those advances and use them to our advantage.
Absolutely. And collaborate too, Share what we know and what we've seen with each other. Go to conferences, read the latest research.
So it's a team effort.
Always. The more we work together, share our ideas, and learn from each other, the better we'll be at diagnosing and managing these conditions.
That's a perfect note to end on. Collaboration, never stop learning, and being dedicated to giving our patients the best care. That's what it's all about.
Couldn't have said it better myself. It's been a real pleasure diving into this with you.
Same here. And to our listener, thank you for joining us on this journey into the world of neurofibromatosis. Keep those brains working, keep your eyes peeled, and keep making a difference out there.